Hi, everyone. My name's Julie Kilpatrick. I'm a research nurse with the immunotherapy team. I work also with the neuro-oncology program here at City of Hope. So I work with those patients that are receiving T cells and are brain cancer patients. My presentation is going to discuss the routes of administration for T cells. Primarily, my focus with brain cancer patients is a regional application rather than IV delivery of CAR T cells. However, there's multiple ways to give CAR T cells, and that's what we want to talk about a little bit today. The first slide is showing the general process of creating the T cells and making it prepared for the patient to receive. The first phase involves the process of determining if the patient is eligible for leukapheresis. And that process of leukapheresis is a procedure where the blood is drawn from the patient and processed through a machine that separates out the white blood cells, including the T cells. Those cells are then isolated and sent to our manufacturing lab. And at that point, the T cells and the rest of the white cells are separated so that the T cells can be genetically modified. That genetic modification is done, involves a gene encoding the CAR T cells using viral vectors such as lentiviruses, retroviruses. The CAR typically consists of an extracellular antigen binding domain, a transmembrane domain, and an intracellular signaling domain. The genetic modifications that are made to these T cells allows them to have the ability to recognize and bind to the tumor cell when it's reintroduced into the body and thereby fight the cancer. Once the cells are prepared and have been modified, they're then allowed to grow and expand so that they can grow to large numbers, because we need quite a few cells when we're giving these T cell administrations. For our studies with the brain program, we're giving multiple injections. It's not a one-time infusion. It's done over several weeks. So most of the studies that I'm in charge of will have 3 to 4 injections as the primary baseline. If the patients are able to have additional cells, if enough cells expand and we have quite a number of cycles available, then we can give those optional doses as long as we have cells remaining. Once the cells are prepared, they're then frozen and then put aside and allowed to just wait till the patient is ready and in need to have the treatment. We've had some patients that have been on standard care and it's been holding their disease in place. So those cells are sometimes frozen for months to up to a year, and we're still able to use them at the time that the patient comes back with the need. There's also conditioning, which is lymphodepletion that can be done and is most often done with hematological cancers, but we've been introducing that also in our brain studies as well. Lymphodepletion involves the patient receiving some preliminary doses of chemotherapy intravenously that make room in the bloodstream for the T cells to expand and hopefully proliferate more rapidly. The route of administration of CAR T cells plays a crucial role in determining treatment efficacy, safety, and patient outcomes. The reason it's so important is because targeting specific tumor sites can be difficult. Different routes of administration allow for targeted delivery of CAR T cells to specific tumor sites. For example, intravenous administration enables a widespread distribution of CAR T cells throughout the body, while intratumoral administration delivers T cells directly to the tumor lesions. This targeted approach can enhance the effectiveness of CAR T cell therapy by maximizing tumor cell killing while minimizing the off-target effects on healthy tissues. Optimizing tissue penetration is done by can be influenced by the route of administration. It allows the ability of CAR T cells to penetrate and infiltrate solid tumor tissues. Intratumoral administration, for instance, allows for direct access to tumor microenvironments, overcoming barriers to T cell infiltration often encountered with solid tumors. This can lead to improved tumor cell killing and therapeutic outcomes. Certain routes of administration, such as IV and sub-Q infusion, may result in systemic distribution of CAR T cells, potentially leading to systemic toxicities, such as cytokine release syndrome and neurotoxicity. By contrast, localized delivery systems, like intratumoral or intrathecal administration, may reduce systemic exposure and associated toxicities, thereby improving the safety profile of the CAR T therapy. Future directions look at ongoing research being done in novel routes of administration and delivery strategies to further enhance the therapeutic effect of CAR T cell therapy. Routes of administration include intravenous, which probably most people are the most familiar with, and this is done with either a peripheral IV or a central line. The process is administered through either a single infusion or multiple infusions. The advantages to intravenous administration are that it distributes a widespread dose of CAR T cells throughout the body, targeting both systemic and metastatic disease. Limitations to this type of delivery would be that it could result in more systemic toxicities, such as cytokine release syndrome and neurotoxicity due to the nonspecific targeting of healthy tissues. Subcutaneous administration is CAR T cells that are injected directly into the subcutaneous tissue, typically in the upper arm or the thigh or the abdomen. The product is administered as a subcutaneous injection, similar to vaccinations. The advantages of this would offer less invasive alternative to receiving CAR T cells, potentially reducing the risk of systemic toxicities. However, the limitations would be on the efficacy and the safety compared to other routes of administration. Intratumoral administration is more or less what my focus is with the studies and the patients that I deal with. It's not only intratumoral, but intraventricular. So this is an area where you can actually inject the cells into the site of the tumor, directly penetrating that tumor area so that you're overcoming some of the physical barriers that would limit CAR T cells from being effective on solid tumors. The limitations to this are applied to the accessible tumor lesions. Sometimes the tumor isn't in an accessible location, and it may not be feasible if there's widespread disease. For instance, with brain tumors, there can be one single tumor. However, there are microscopic areas of tumor that we can't see or would be distant from the original tumor. So injecting only into that one tumor site would not really benefit the patient overall. So typically what we'll do with those patients is to give the T cells both in the tumor area as well as into the CSF, into the ventricle, so that those T cells can then penetrate throughout over the brain and the spinal column. So just to reiterate, the intravenous infusion is primarily used with hematological malignancies. And then when we were able to use a more direct approach to solid tumors, we overcome some of the hurdles that are presented to us, such as not being able, when the T cells are administered into the bloodstream and we're trying to make it to a solid tumor, you're not getting the most of that particular product to the tumor site. It's being distributed throughout the body rather than going directly to the site where you want it to do its work. So there could be inadequate expansion of the T cells at the site of disease. And then the tumor microenvironment can also inhibit the ability of the T cells to be effective. Rationale for CAR T administration for solid tumors involves delivering CAR T cells directly into or near the tumor site. Here's a detailed rationale for this approach. Overcoming physical barriers allows solid tumors do create a physical barrier against the T cell or against any treatment, any kind of even chemotherapy, such as a dense stroma or hypoxic areas that impede the penetration and infiltration of immune cells. Regional administration allows for direct placement of CAR T cells into the tumor microenvironment, bypassing these barriers and enabling effective tumor killing. We can, by having regional administration of the CAR T cells, it allows for direct access to this environment and is able to be given directly in the area or region where the tumor exists. Compared to systemic administration, such as IV administration of CAR T cells, regional delivery minimizes systemic exposure of CAR T cells, thereby reducing the effects of systemic toxicities such as cytokine release syndrome and neurotoxicity, limiting the distribution of CAR T cells to the tumor site or regional lymph nodes, helps spare healthy tissue from off-target effects, improving the safety profile of the therapy. We're also looking at combining CAR T cells with other therapies. Regional CAR T cell therapy administration can be combined with other local or systemic therapies, such as radiation therapy or immune checkpoint inhibitors, to achieve synergistic effects. Combination approaches may enhance the anti-tumor immune response, overcome resistance mechanisms, and improve overall treatment outcomes in patients with solid tumors. It also gives the potential for repeat dosing. With regional administration, it may facilitate repeat dosing of CAR T cells as we do with our brain cancer patients, allowing for multiple treatment cycles or subsequent therapies to sustain anti-tumor responses and prevent disease recurrence. This flexibility in dosing regimens may be particularly beneficial for patients with recurrent or refractory solid tumors who require long-term disease control. So in order to allow us to be able to deliver these T cells to the appropriate area, we do need to place a device in the skull in order to have a port for the T cells to be administered. So the picture on the right shows a Rickham catheter. This is a small catheter about the size of a dime, the dome, and that is implanted in the scalp by the neurosurgeon prior to starting T cells. They make a small burr hole in the skull, guide the catheter down into the ventricle or into the bed of the tumor, and then the Rickham reservoir sits on top of the skull, covered by the skin. So that's going to be our port that we use to administer CAR T cells. Either for us, it's on a weekly basis until the T cells we run out of product. That's usually done about a week or so prior to the beginning of CAR T cells. So we want to make sure we have our product prepared, ready to go before that placement is made, because we don't want to have a catheter put in and then the product doesn't come to fruition. So we want to make sure we have a good product before we go through an invasive procedure like placing a device. So this is a picture of what the scalp looks like when we're ready to give the CAR T cells in the clinic. The area is just a small, once it's under the skin, it looks more like the size of a quarter, but that's the area that the physician or the practitioner will access and deliver the T cells. I have a short video that I'd like to show, if I can play that. It just shows the typical process of giving our T cells in a day. So the preparation is getting the patient prepped, applying IMLA. Not all facilities use IMLA to prepare. This is just all the equipment needed to sterilize the area. So it's very important that you feel for the site. It's much easier to access by feel rather than appearance. So then she will draw back, check for the presence of CSF to make sure we're in the it's in properly, and then the T cells are administered. Because there's that tubing involved in the delivery of the T cells, there needs to be a flush afterwards in order to make sure all of those T cells are completely administered and we don't leave no cell left behind. We do it over 5 minutes, the total procedure from start to finish of the starting of T cells to completion of the flush. And then we monitor the patient for 2 hours afterwards for any type of side effect. So we rarely see, I think the nurses here from our infusion area can tell you as well. We rarely see immediate side effects in our brain study patients that are there during the time that they're receiving the cells in clinic. Typically, those side effects start to occur when they go home, usually late in the middle of the night. They maybe wake up with a fever or chills or a headache. Those type of side effects are what we're most commonly have experience with. So just to give a brief timeline of what happens when the cells are prepared the day of collection. We do the collection, not the day of the collection, but the overall view of what happens when a patient is receiving CAR T cells. So the collection and manufacturing is completed. That can take 4 to 5 weeks from the point of leukapheresis to the final product being released for use. Once the CAR T product is prepared, then lymphodepletion starts, and that sets in motion the timing of our first day of delivery of T cells. Typically, it's about 3 to 5 days of lymphodepletion, and that happens just a few days prior to this first day of T cells. For the regional administration, a port is needed. So with my patients, we place that port in the brain. For patients that are on ovarian T cell trials, they have a port placed in their abdomen, and the T cells are administered through that port. And then it's interesting in those trials, the T cells are administered, and then the patient is, in order to get those cells distributed, the patient is then turned back and forth during the course of receiving the cells in order to make sure that they're reaching all the areas that are important to where the tumor cells may lay. Covered all that. On the day of T cell infusion itself, this would be different for each institution, obviously, but in our institution, we have the patient come in early in the morning. We evaluate the patient for signs of infection, for lab abnormalities. We have the orders there available for the physician to sign, and we have what's called an RTA note, which is a research toxicity assessment. So we're making sure that they're not coming in with any toxicities that should prevent them from receiving the cells that day. And that's sort of our green flag that if they meet all of those criteria, then they may proceed on with the rest of the plan for the day of receiving the cells. The orders are signed, the eligibility is confirmed, and we send that to our manufacturing lab where they will then thaw the cells that have been previously made. Once they prep the cells, they will send them to the sterility lab where they're then double checked again to make sure there's still viable cells and there's no presence of any type of bacteria. So they do cultures and fungal checks on these cells. This takes about 3 to 4 hours in the morning. So the patient doesn't stay and just wait in the clinic during all that time. They would go back to their hotel or to their home or wherever they're staying. After we see them for the initial visit in the morning, they go back to where they could rest for a few hours and then return to receive the T cells. In our case, they come to our Briskin Infusion Center, and they're greeted there by our Briskin nurses and staff, and they're placed in a private room where they are prepped with Tylenol and Benadryl, and then Imlacreme to the infusion site. And once the cells are ready, then the research team comes over, myself and the provider that's going to be doing the injection, to actually deliver the T cells. Once the cells have arrived, the overall time that we are with the patient in the room is about 20 to 30 minutes, including what you saw with the preparation and the injection and then the follow-through. This is just showing some of the different areas that regional CAR T cell administration is being used. My area is glioblastoma, but it's being also used in pancreatic, renal cell, breast cancer, ovarian, melanoma, sarcoma, head and neck, and probably others that I don't have listed here. As far as future innovations and directions, there's studies being done on using hydrogels, nanoparticles, and different kinds of scaffolds in order to sort of protect the T cells as they are carried to the site of where they need to do their work. So to prevent them from being destroyed before they get there, some of these newer technologies may just prepare them for that hostile environment that they may be coming into.
Good morning. So my name is Sarah Miller. I'm a nurse up on the 6th floor of Helford here at City of Hope. I've been a nurse for about 4 years, and I will disclaim, when I gave this presentation to my husband, he said it was very dry. So I hope you don't feel that way. But I will tell you that the act of being able to give CAR T cells to patients and take part in these clinical trials is anything but dry. So if you take anything away from that, just know that. I don't have any disclosures during this presentation, no conflicts of interest. So I think CAR T cell therapy is very neat. So when I started back in March of 2020, at the time, there were only 2 FDA approved products for CAR T cells. So it's still very new, especially to nurses on my floor. So it was very intimidating originally to give those types of cells. And from when I started in 2020 until 2022, there were 4 new approved products in addition to those 2 for a total of 6. So we currently have Abecma, Breyanzi, Carvykti, Kymriah, Tecartus, and Yescarta. So just in that short time, so from 2017 to 2022, so in 5 years, we've had 6 new products available. And then as Dr. Buddy mentioned, it sounds like there's more on the horizon. So the CAR T cells are currently used with patients in relapsed or refractory disease, typically myelomas, lymphomas, and then ALL as well. The T cells are collected through a process called leukapheresis, and they're taken from the patient, so it's an autologous transplant. They're transferred to a lab where they're genetically modified using an inactivated virus in order to present a receptor to target the antigen of malignant cells. This is typically the CD19 or B cell maturation antigen. So when this is done, it can cause cell death on the specific sites of the cancer cells. So the cells multiply to a sufficient quantity, go through quality checks, and then they're frozen, sent back to the facility in order to be transfused back into the patient. Patients typically undergo lymphodepletion, so about 5 to 7 days prior to infusion, and this typically includes cyclophosphamide and fludarabine. Because the T cells are so specific to the cancer cells, this can cause rapid cell death, which has a few different side effects. So some of this can be tumor lysis syndrome, which shows as hypercalcemia, hyperuricemia, hyperphosphatemia, and then hypocalcemia. You also can get cytokine release syndrome or CRS, which will be discussed later on in Module 2, as well as ICANS, which again will be discussed in Module 2. So these are can be severe side effects, so it's really important for whoever's administering these products and watching and monitoring these patients to be aware of it, so they know when to intervene so the patient can have the safest possible outcome. Patients should be monitored at a REMS facility for about 7 days and remain close by for around 4 weeks. They also should be advised to avoid driving or operating any type of heavy machinery for at least 8 weeks post-infusion. So the administration of CAR T cells, the RN must complete REMS training. So this is specific for each of the different types of products. The infusion is typically given through a central line, which is preferred. So whether it's a PICC line, a Hickman, port, anything like that. You can also do free-flowing peripheral IVs. You just want to make sure that the gauge is large enough to handle that. It's infused with normal saline. The infusion is given through a Y administration set without a filter, with the exception being Carvykti. So that's a picture of the type of tubing that we use here at City of Hope, which recently changed. It's almost similar to blood tubing, except it doesn't have that filter in there, so that way none of the cells get filtered out. So it's important when you do the priming of the tubing that you have to prime each set individually with the normal saline so you don't get air in the line. With some of the products, every single one can be infused via gravity, so you don't typically use the IV pump. However, some of the products say that you can use a peristaltic pump as well. It requires 2 licensed personnel verification. So at City of Hope, it typically takes 1 nurse and then usually someone from the stem cell lab to come up, as they're the ones that are thawing the product. But it could be different based on your facility. So just make sure you know who the second licensed personnel can be. It's important that you complete a baseline ICE score or ICE score prior to doing the infusion of cells. I would also recommend doing it prior to pre-medications, because most of the time it can be Benadryl, and that usually makes patients very sleepy. So not always a good indicator if you've done it after that. So what the ICE score is it's scored out of a score of 10. And we can break it down which components have each number score. So you have 4 points for 1 point for name, patient's name, 1 point for the date, the hospital that they're in, the name of it, and the city that that hospital is located in. So they get 1 point for each of those correct. Obviously, they miss the point if they get it wrong. We ask them to name 3 objects around the room. It can be any objects. I usually try to do things that I know the patient's going to know the name of and not something tricky like something to do with the IV pump. So they get 1 point for each of the correct objects that they name. Then we have counting down from 100 down by tens, 100, 90, 80, all the way down to 0. So doing that correctly is just only 1 point. Following commands, typically ask them, can you close your eyes, stick out your tongue, take your finger, touch your nose? And then if they're able to complete those, that's 1 point. And then we have writing a sentence. So here at City of Hope, we have them write sweet as apple pie. So we take that sentence that they write the first time and we use that as our comparative each shift that we complete this assessment. You still get the point if you're able to write the sentence, even if maybe they'll add an extra letter to it. Maybe the writing will be a little bit more squiggly than it was at baseline. They still get the point for it. You only don't get the point if you're not able to write it all, which can happen sometimes. So for the actual procedure, so like I was just saying, you want to complete the assessment, including that initial ICE score. You want to verify that there are 2 doses of tocilizumab with the pharmacy, and that's per patient. So each patient needs to have 2 doses on hand. Like Dr. Buddy mentioned earlier today, there has been a shortage with that. So it's really important that you make sure that those are there before proceeding with the infusion. You also want to make sure that the patient has the wallet card. So when they're signing up to do the CAR T therapy, they should get a little card that they keep in their wallet to signify that they've had this procedure done. In case of emergencies, they can show that so other places know that the patient has had this procedure. You administer the pre-medications 30 minutes prior to the infusion. This is typically acetaminophen and an H1 antihistamine, typically Benadryl. You set up the tubing. So again, both sides need to be primed with that normal saline. The product arrives, you verify the patient identification with 3 verifying factors, typically patient's name, birth date, MRN. You want to verify the product. So typically when you scan the product into the computer, you make sure that everything matches up. It's the patient's name, it's the same numbers and everything. And then you want to visually inspect the product. You don't want anything to compromise the product. So if there's any holes, anything leaking, then that needs to be addressed right away. Interestingly, when you look at the packet inserts for any of the 6 FDA-approved products, there's no information on vitals, so just do vitals per your institution policy. When you're doing the infusion of cells, typically 30 minutes you have to infuse once it's thawed. However, because things can't be the same for each product, some of them can actually you can have more time to do it. So a Abecma, you get 60 minutes from the start time of thaw, stable for 2 hours. Carvicti, you get 150 minutes. And then Breyanzi, 2 hours from when it's removed to administration. So I always tell the nurses that I train, if you've ever given stem cells, which you have to infuse within 10 minutes, including a flush or 2 flushes, you can give CAR T cells because you have 3 times the amount of time and it's usually a smaller volume. So much easier than giving stem cells, in my opinion. So you rinse the bag, same thing with stem cells, where you take the bag down. You want to make sure that you rinse it to make sure you get all corners of the bag so the patient gets all of the T cells. The end of infusion is actually going to be after the rinse is complete, so it needs to be in that time frame. You monitor for 2 hours post-infusion. You're looking for things. Expected events can be fever that's less than 30.3 degrees Celsius, mild rigors, headache, nausea, vomiting, or flushing. Something that would be more unexpected is fever greater than 38.3 degrees Celsius, severe rigors, tachycardia, bradycardia, and/or hyper or hypotension. So typically with these expected and unexpected events, most of the time it can be related to the preservative that's used when freezing the cells to make them viable. So I always try to reassure patients and let them know that you're not having a reaction to the CAR T cells when you're doing the infusion. It's typically just the preservative. But luckily, because the volume is smaller than stem cells, as well as you get a longer amount of time to infuse it, most patients tolerate it very well, and you don't typically have to worry too much. You want to complete the ICE assessment every shift and as clinically indicated. If a patient or family member is telling you something seems off, then I would recommend redoing the ICE assessment, because the faster that we can intervene when we've noticed that there's a change, the better outcomes patients have. You also monitor for signs and symptoms of cytokine release syndrome, fevers, hypotension, increased oxygen needs, things like that, to make sure that the patients are doing okay. So one thing that I've had the opportunity to take part in the last, I think we started it early in 2023, is CAR T cells and ovarian cancer. So this is when I say, if you have the opportunity to jump in and, be the nurse that gets to take charge of, doing a first research thing, I would do it. It's very interesting. It's very exciting to get to be a part of it. So here at City of Hope, we're doing IRB 20034. It's a phase 1 study looking at CAR T cells that target the TAG72 antigen of ovarian cancer. It's actually pretty similar to giving CAR T cells with some key differences. So the first is that it's actually infused, instead of doing it intravenously, it's infused through an intraperitoneal implanted port in the patient. It requires warm normal saline intraperitoneal infusion pre and post CAR T to allow, because the amount of CAR T cells you infuse is so small that if you put it into that cavity, it would just, if you move it around, it's such a small amount. So you give this saline to be able to cover more area of the intraperitoneal cavity. So with that, the patient actually has to be turned every 15 minutes side to side. And then every 30 minutes, they Trendelenburg and reverse Trendelenburg for 4 hours post T-cell infusion. And if you remember, pre-T-cell infusion, you get Benadryl. So you're waking this patient up pretty much every 15 minutes to try to turn positions to cover the entire cavity to make sure that it's going everywhere it needs to. So originally, the first couple of patients that we did it with, they were done without the preparative chemotherapy, but now they're starting to introduce that chemotherapy with these patients. So it's something that, you can look for in the future for the results of it to see how it's doing. But it's very exciting to get to be at City of Hope and take part in these things. So would highly recommend.